I may be in the minority out there, but I'm overall very favorable of still using DC MRI as a part of our prostate MRI portfolio. And I'll tell you the reasons. First, most people do not use endorectal coil nowadays for prostate MRI. Then you run into getting really low quality diffusion weighted imaging uh, without using the endorectal coil. Then the most important sequence that you have, which is DWI, the image quality gets degraded. So therefore, DC MRI can actually help you a lot more than you think in detecting cancer in those cases. Second reason, there are certain areas in the prostate that DC MRI really helps you identify and differentiate normal prostate from cancer. Those areas is anterior fibromuscular stroma, which is the most front part of the prostate, and another one is central zone. In those areas, I still use almost every day to differentiate normal prostate tissue from cancer in those locations. Thirdly, I think based on our studies, probably we don't need to give the full dose in prostate MRI, full contrast dose in prostate MRI, especially if you want to do quantitative analysis. In fact, 20%, even 15% of the whole dose may actually give you more robust results, especially in terms of quantitative analysis, as we demonstrate in our publications. And fourthly, there's still good evidence that these CMRI parameters can help you differentiate and understand the aggressiveness of prostate cancer. So overall, based on these reasons, I would still like to keep the CMRI in my multiparametric MR portfolio. Thank you.
So the dynamic contrast enhanced MRI has a limited role in evaluation of prostate MRI per PIRATE's guidelines. I kind of agree with that because the de novo lesion detection capability of dynamic MRI is lower compared to T2 or diffusion weighted MR imaging. The most common use for me for dynamic MRI is to further confirm the already detected lesions, natures, or angiogenetic properties. There's a minimal fraction of lesions, about 10 to 15%, which can show up on dynamic contrast enhanced MRI in presence of subtle findings on the other pulse sequences. But again, the significance of these lesions is also not very clear. I think the most helpful use of dynamic contrast MRI, contrast enhanced MRI in prostate cancer care is study further like evaluation of people who undergo focal therapies to find out residual recurrent disease, or people who undergo surgery or radiotherapy. I think the role is more visible in those indications. At this stage, for treatment-naive patients, maybe we will need some prospective, larger-scale trials to understand its real role. But I am feeling like the shift is towards use of dynamic MRI in treated patients to guarantee to exclude residual recurrent disease.
Well, I've been using contrast or dynamic contrast enhancement on all my prostate studies for over 10 years now. Most of my patients are being evaluated for high or clinically significant prostate cancer prior to biopsy. And what I found is that using contrast or the dynamic contrast DCE sequence, it really hasn't added a lot to the identification of clinically significant cancers. It's either been supportive or non-contributory. So if we are using it for, or if we're doing an evaluation of a patient for screening prior to biopsy or for fusion, I don't think it's as necessary as it is if a patient has had surgery already. I mean, DCE is critical in patients who have had prior definitive therapy for prostate cancer to evaluate for recurrence. However, given the fact that we usually give our urologists adequate information to help them direct or focus or fuse the imaging for biopsy without contrast, I think probably it'd be better to try and reevaluate the screening protocol for prostate MR to decrease the time, decrease the cost, and also reduce the exposure to gadolinium.